And in non-Hodgkin's lymphoma, what about the role of CD30, Brentuximab, other things that may target CD30?
So Brentuximab Vedotin is this drug antibody conjugate. It's been approved for use in relapsed Hodgkin lymphoma and in relapsed anaplastic large cell lymphoma. These are diseases that typically express a lot of CD30 antigen on the cell surface. What is quite interesting and will be discussed at this year's ASH meeting is the fact that some proportion of cases of diffuse large B-cell lymphoma express CD30. Maybe 15, 20, 25% of large cell lymphomas, and to variable amounts, 1%, 5%, 10%, 30% CD30 expression. But there is an ongoing phase 2 trial of Brentuximab Vedotin in relapsed refractory diffuse large B-cell lymphoma. And for a patient to get on that trial, they just needed any amount of CD30 expression detected by immunohistochemistry, even 1%. And what is amazing is the single agent response rate in that trial is running right around 40% right now. Responses are rapid, they're reasonably durable, and so far there's no correlation with the amount of CD30 expression on the cell and your likelihood of response to Brentuximab Vedotin, which is kind of a counterintuitive observation, but a fascinating one. So it'll be interesting to see if Brentuximab Vedotin can find a home somewhere in the management of diffuse large B-cell lymphoma, which is a place, quite honestly, where we need more agents, we need more options. Diffuse large B-cell lymphoma isn't like CLL or even follicular, where we have a lot of agents to choose from and a lot of effective agents. There's actually a relative paucity of good agents for relapsed diffuse large B-cell lymphoma, so I hope this one turns out to be a winner there.
Do you think it's just another way of delivering cytotoxic chemotherapy to relapsed DHL or DLBCL, or is it something else?
I think it's a fancy way of delivering cytotoxic chemotherapy, but if it works and the toxicity's not bad, then who cares? Who cares how you kill the cells, as long as it's working and it's effective and the toxicity is not too bad.
But isn't it amazing how some of these immune toxins, are active in Hodgkin's, and you're talking about diffuse large B-cell lymphoma, and as compared to what's been seen in other diseases where they've been applied. I mean, Mylotarg, for instance, in AML, you saw very short responses. And
do you think, should we be measuring CD30 on all of our diffuse large B-cell lymphomas? Should that be a routine stain that our hematology pathologists should be doing? Should they be doing FISH and immunohistochemistry for MYC and BCL2 routinely on every diffuse large B-cell lymphoma? Are we at that point, and are there other things that we should be measuring routinely?
Well, yeah. I mean, at our institution, just in the last 6 months, we've started doing immunohistochemistry on every new large cell lymphoma for MYC and for BCL2. And before this ASH meeting, it had not occurred to me to look for CD30 on our diffuse large B-cell lymphoma patients, but yes, we may need to start doing that now, because if you can find it at all, then there's a commercially available agent that you might be able to use in a relapsed diffuse large B-cell lymphoma patient. And I know there's interest in trying to move that agent up front in diffuse large B-cell lymphoma management. Whether it finds a home there or not remains to be seen.
I have a provocative question. Is it possible that these anti-CD30 drugs are working directly on the tumor cells or indirectly via the normal immune system, somehow modulating? It's still a T-cell drug, so do you think it's directly active against the malignant cells?
Well, I'd always assumed it was directly active against the malignant cells in Hodgkin's and in the anaplastic large cell lymphomas, which are strongly CD30 positive. So I just assumed it was analogous to Brentuximab. Right. The fact that it's showing activity in large cell lymphoma, even in cases that barely express CD30, does make one think that there could be other mechanisms in play, but I can only speculate.
And again, as a bridge to transplant or as a management after autologous transplant failure?
Well, You know, as a bridge to transplant, right now most patients receive standard therapies such as rice or our DHAP, and so it would have to supplant that or add to that to find a home there. So, you know, certainly there are a lot of relapsed large cell patients who don't make it to transplant because they don't respond appropriately to rice or to our DHAP, or you can't mobilize, and so there's lots of room for improvement there. And if we could find an active agent that would be an effective bridge to transplant, that would be a major therapeutic advance for large cell lymphoma.